plate you can use is drawing. Here's a picture a kid drew, and you can see there's a boat there, there's a helicopter with somebody, they're rescuing somebody on the helicopter, pulling them up on a stretcher. I wonder if this kid has a parent in the military that was either on a boat or a helicopter, or maybe there was some sort of emergency rescue that they saw or were part of. Maybe they came on a helicopter themselves to the hospital. Probably not from a boat, but who knows. And then box 6-4 in your book has some really good techniques for creative communication with kids. I would suggest looking at that. Performing a health history. Children's Hospital has the admission database that they do, and with everything having just gone electronic, this is something we are very unlikely to do, but if you're working with a nurse who's admitting a patient, go ahead and help out. But that's something we probably wouldn't do on our own. But part of that health history with a child, just like your adult, you're going to get the chief complaint, what brought them in, what's going on with them, what their present illness is. On the health history on a child, we want to also make sure we get things like the birth. Was it a cesarean section? Was it a vaginal delivery? Were they born term, preterm, post-term? So kind of a good picture of the birth history, which makes a big difference in what we might be treating on this child. Get a dietary history. You saw how many different formulas there are at Children's Hospital. So what if this is a baby, what formula they're on? If they're an older child, what foods do they eat? Kids don't want a new experience with food. They want to come to the table and meet an old friend on their plate, not have a new experience. So let's figure out what they will eat so we're giving them the right stuff. Allergies, obviously important. Any previous illnesses, injuries, or operations, we want to include that. Any medications they're on at home. Their immunizations, we want to know if they're current on their immunizations. And if not, we're probably going to get them caught up while they're there. Growth and development. We're going to plot them on a growth chart. It's important to know where they've been, though, because if they're currently at the 5th percentile, that's significant. If they've been at the 5th percentile their entire life, mom is 4'11" and dad's 5'4", well, they're probably going to be at the 5th percentile their entire life, and that's normal then for them. So find out what that growth and development history has been. Habits. You'll see at Children's they ask, how many naps does your child take? And we try and match that. If this is a kid who's used to a couple naps a day, we try and work that into their care. So we're not keeping them awake all day when they're used to taking 2 naps. If you've got a teenager, you need to ask about sexual history. And obviously you should do that without the parents in the room if you want them to get honest answers, and that could be important. Family medical history. You ask that with adults too, but that's important. There's certain things that are familial. And then family structure. And I always word this as who lives in the household with the child. If you just ask who's part of the family, that's not necessarily a real clear question to everyone, because who lives at home and who you consider part of the family may not be the same thing. And really what we want to know is, are there other people in the household sick? And what has this child been exposed to? Who's going to be the support people coming in to be around them? General approaches towards examining a child. What we want to do with the physical assessment is do the least invasive things first, the most invasive last. Our head-to-toe assessment, we're going to have to change that a little bit. And it's going to depend on the child and the developmental level of that child. And then try and prepare the child beforehand. Stethoscopes are kind of fun. They look like a toy. So letting the kid look at that and touch that before you put it on them, they're usually pretty cooperative with that. And here's some kids playing with stethoscopes. Like I said, they're really kind of fun. They look like a fun toy. Okay, growth measures. Kids up to 36 months at Children's Hospital, we're supposed to use the the baby scale. So if they're an infant, you lay them on it. If they're an older child, they sit on it. And so we do a weight and a head circumference, and the length we're going to do laying them down on the bed and measuring them from crown to heel. For a kid over 3, so 37 months, we start with the standing scale, and that's got the standing height on it as well. And then we want to plot those onto the growth chart. Be sure you get the right growth chart. They're separated by gender. They're separate ones. If the child was premature, we want to adjust for that prematurity. So we're looking at how old they would be from their due date, not their actual birth date. There are separate ones for things like Down syndrome or some of our more common disorders, because those kids don't follow the standard growth chart, but they do follow a growth chart for their group. Any kid who's below the 5th or above the 95th percentile, that's considered outside of our expectation, and we need to evaluate why. Here's a picture of how to measure a baby. You're going from the heel to the crown of the head, and you do that with them laying down. What I always do is use a pen and mark on the sheet. Probably does not make the laundry happy, but that's the easiest way, and then measure between those marks. Laying a measuring tape next to them, it's hard to keep them still long enough to really get that measure. But you're also measuring around the head circumference, around the fullest part, so it's usually right along the eyebrows, and then the biggest part of the back of the head, around the chest and around the abdomen, and usually that's right over the umbilicus. Different kids are going to be different. Here's 2 8-year-olds. Look quite different. An 8-year 1 month old versus an 8-year 11-month old is probably going to be very different, but 2 8-year 11-month olds can be very different in size and in weight. So again, we've got to compare to where they've normally been on the growth chart. Okay, vital signs. This is what your book suggests, is counting respirations first, and you can do that before disturbing the child at all. Just kind of standing back without touching them and count. With kids, you really want to try and do a full minute, particularly babies. They're periodic breathers. If you count during the rapid breathing or count during the slow breathing and only count for 15 seconds and multiply it, you're going to get a huge difference. So it's best to count for a full minute. I would say do at least 30 seconds and multiply by 2. Don't do the 15 seconds and multiply by 4. We also want to count an apical heart rate, and that's for an apical heart rate is always for a full minute. Again, stethoscopes are fairly fun, especially if you kind of hold it out and let the child touch it first and then put it against their heart. They'll usually let you do that. Your book says do blood pressure third and temperature last. I would say this depends on the kid, which is going to be more traumatic, the blood pressure or the temperature. Now, for temperature assessment, you want to see what they've been using on that kid and try and do the same thing. If you're going to change the method you use, the recommendation is that you take it the way it was done before and the new way, just to be sure how close those are. The standard at Children's Hospital, their policy is that children under a month all get axillary temps. There's too much risk of perforating the rectum, so we do an axillary temp. The policy after that is between 1 month and 1 year to do rectal. I don't think you're going to see very many nurses do that. They pretty much do axillary up to a year, and they'd only do rectal if there was really concern that the axillary is not accurate, or we have to get a really accurate temperature for some reason. Over a year, you can use the tympanic. The tympanic, you've got to do it right. That's probably the temperature assessment method that's the most prone to user error. You're shining the light on the tympanic membrane. So you've got to have it pointed, you put it in the ear, but it's pointed towards the nose, and you're pulling that ear canal so that you're straightening it out so you can get that light against the tympanic membrane. If you just shine it on the skin inside the external canal, you're going to get a really low temperature. It's not going to be accurate at all. And then school age and older, they do oral temperatures. And those are generally a digital thermometer at the end of the bed that's for that patient only.